as one Robert Beale has said, blood transfusion is like marriage. It should not be entered upon lightly, unadvisedly, or more often than is absolutely necessary. It is a double edged sword and it could lead to hazardous results in many aspects. And the most commonly reported causes of transfusion related mortality are TRALI. They also say that minimizing the amount of phlebotomy for the lab samples. If it's a patient who is in the ICU and we are, collecting the samples for the pathology laboratory and, blood tests. So that is a iatrogenic anemia. So we need to avoid that. And our practices should be based on the transfusion triggers. You can just have a quick look at the color of the, plasma, if it is pink, or red cells if they are black, or if there are any signs of the leak or the seams have been opened. So this is all these are the signs that the blood contains bacterial contamination.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your liked videos so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
First of all, I would like to thank Team Medflix for giving me this opportunity to present my talk on this platform. So I hope I will do justice to the topic, and I hope there will be some take home messages for this very important topic on the judicious use of blood. So, uh, so let us start with why we are doing this. Why there is has to be a judicious use of blood. So you all know that blood is not prepared. It's not a. I mean, though it is called a drug and it comes under the Drug and Cosmetic Act, and there are legal requirements to open up a blood bank and to issue blood components, but it's considered a drug, but then we do not get it manufactured in a factory or in a pharmaceutical company. So the human resource is the only resource. So why judicious use of blood? Because three S's: scarcity of the resource, scientific appropriateness, and safety. So these 3 points we will look at when we go through our talk today. So, as one Robert Beale has said, blood transfusion is like marriage. It should not be entered upon lightly, unadvisedly, or more often than is absolutely necessary. So, though it is necessary, it is life saving, but it is a double edged sword and it could lead to hazardous results in many aspects. And the most commonly reported causes of transfusion related mortality are TRALI, transfusion related acute lung injury, and hemolytic transfusion reactions, which could be really fatal. So, just going through what is the transfusion process, how it is, how it starts and how it ends. So, it starts with the decision making. Once the clinician decides that this patient needs transfusion, he will make a request, sample will be taken, and then the blood center does all the processing. And in the end, again, when the blood product is delivered to the patient, the safe administration of the blood product with proper documentation is again an essential step and comes under the purview of the treating physician or the clinical side. So a thorough clinical assessment, a positive patient identification, a written informed consent from the patient, they are very important aspects from the clinical side. So both the stakeholders, the person who is collecting the sample, who is administering the blood, or in the blood center, the person who is doing the blood grouping or processing or the compatibility testing, all these stakeholders are responsible for making the process as safe as possible. So when we look at the good transfusion practices, which is why we are here today, we want to know what is a good transfusion practice. A few points in consideration are: we ask ourselves, does this patient really need the blood products? And what are the alternative options for the treatment? Whether a particular product will be, which of the products will be most effective in providing the desired outcome. And we want a minimum donor exposure because it carries with it its own risks, which we will talk about later. So they also say that minimizing the amount of phlebotomy for the lab samples. If it's a patient who is in the ICU and we are collecting the samples for the pathology laboratory and blood tests, so that is a iatrogenic anemia, causing iatrogenic anemia. So we need to avoid that, and our practices should be based on the transfusion triggers. And there are many targets and guidelines set up by the National Blood Transfusion Council and individual patient assessment. These will make you help you make a correct decision on whether your patient needs blood or not. So few again questions which we need to ask ourselves, or we have to do a risk benefit analysis. Why to transfuse? First of all, whether what is the benefit, and the benefits are more than the risk. Patient's symptom versus the lab levels. We are not treating the lab indices, right? We need to assess the patient clinically, whether we are giving the blood product prophylactically or therapeutic. In some cases, like in dengue patients, or when we are suspecting, or in some bleeding patients, DIC patients, when we are suspecting that there is some uh, we are thinking that there's some bleed is going to happen, then we do it prophylactically. Now, what to transfuse? Whole blood is a no. Absolutely no, no. Whole blood should not be given. Only components should be used. How much to transfuse is again debatable, whether a single unit is useful, or earlier there were studies which they said that single unit has no value. But again, recent again studies, they say that okay, if you can do with a single unit, you can might as well give a single unit of red blood cells. You have to calculate the volume. It should not be a volume overload, especially in the pediatric patients. Then the type of surgery, what type of bleed you're expecting, or amount of the blood loss you are expecting. How to transfuse is again another very important aspect, whether which filter to be used, what rate of transfusion, and warming. My friends, this is the most, very alarming thing which we in our, I'm working in a blood center in a government hospital, and we see this is very common, warming the blood. So clinicians will say that, oh, we need to warm it under the hot tap water, or we need to put it under a hot under a blanket before transfusion. Well, it leads to hemolysis of the red cells, and it is a very, very wrong practice. Again, as I said before, the risk benefit evaluation should be there, and most of the patients are receiving unnecessary transfusions. Either it is over or inappropriate components are transfused. So what are the risks? Just to take you through some risks which are associated with transfusion. Alloimmunization, risks of the transfusion transmissible infections. We are in the blood center screening for 5 major infectious diseases: HIV 1 and 2, hepatitis B and hepatitis C, syphilis, and malaria. But apart from these, there are so many innumerable viruses which are floating, and the donor might be having, and we are not screening for it. So, increased risks of transfusion reactions, increased incidence of the post operative infections, other known and unknown risks. Apart from these, which are known, the hidden costs are the increased cost. So, the burden on the blood transfusion services in terms of the blood stock inventory, the blood center has to maintain a proper stock of blood units, and of course, the cost is increased when we are doing a blood transfusion. So, what is your role? What is the clinician's role? It's very, very important to assess the need for the transfusion. So, whether the blood loss, whether it is internal or external bleeding, hemolysis in malaria or sepsis or DIC, cardiopulmonary status also has to be assessed, the assessment of anemia, patient's tolerance to blood loss, anemia, age, what age the patient is, and whether there are any other associated diseases, and the anticipated need for the blood, suppose in which surgery how much bleeding or hemolysis is expected. So, coming to why we need components. So, because the concept is that we have to give only what is needed. Different storage conditions are there for different blood components. We'll go through it in the coming slides. And we have to conserve a scarce resource and optimization of blood donation. From one whole blood donation, we can prepare four components: the red blood cells, the cryoprecipitate, the fresh frozen plasma, and the platelets. So, optimizing the scarce resource is there if we are giving using the components. So, also we have to give what is needed. If we to increase the oxygen carrying capacity, we give red cells. If a patient of thrombocytopenia, we need to increase the platelet count, we give platelets. If in the multiple clotting factor deficiency, we can give the fresh frozen plasma. And in the patients of hemophilia or hypofibrinogenemia, we can give cryoprecipitate, which is rich in factor 8. So, just brief about what is component and what is fraction. Fractions are like the albumin and the immune serum globulins. This we cannot prepare in the routine blood centers or blood banks. Now they are called blood centers, but they have to be prepared in a fractionation plant. But a regular blood center will can prepare a blood component which is prepared from a single unit of blood and which is separated by physical or mechanical means like centrifugation and like the red blood cells and the so the basic principle is that based on the specific gravity, these are separated after the centrifugation and we prepare the components. So just to enumerate, the red cell containing components are the packed red cells. They can be leukodepleted also for certain patients. Then the platelets with the random donor platelets, the single donor platelets, the platelet-rich plasma. The plasma products are the fresh frozen plasma, cryoprecipitate, and cryopoor plasma. And these are the plasma derivatives, the factors and the albumins and the immunoglobulins which are prepared in the fractionation plant. So coming to let's see one by one each of the components. The whole blood, when we talk about whole blood, it is either a 350 or a 450 ml of unit, and it has got an anticoagulant of 49 ml in a 350 ml bag and 63 ml in a 450 ml bag. So this is the whole blood. It is stored at 2 to 6 degrees, and it will provide all the mainly for the oxygen carrying capacity and increases the red cells. It has got red cells, and but it has also got some extra volume, potassium citrate. So these things are unwanted. So the use of whole blood is now not indicated much these days. So it is not advisable. Coming to the packed red cells, which we prepare from the whole blood, the red cell component, there is a red cell cells in the additive solution. So when we are doing a red cell, preparing a red cell component and adding 100 ml of a nutrient preservative to it, like it is sagum. So it will lower the hematocrit because the hematocrit will be lower, so it will be easy to transfuse. A better flow rate will be there, and the preservation also will increase to 42 days. Lesser hemolysis will be there to the patient, and again the indication is the same as the whole blood. It increases the oxygen carrying capacity in the symptomatic anemia. So when we use the leukocyte reduced red cells, they are indicated in certain number of patients like pediatric patients or multi-transfused patients like thalassemia who are needing repeated transfusions. So this leuko-reduced red cells will, this component will give you, it will prevent the febrile transfusion reactions because the leukocytes are the main culprit behind the febrile transfusion reactions, and it will also prevent alloimmunization. And washed red cells or frozen red cells also can be prepared. So this is a filter, lab side filter, which is used for the leukoreduction of the red cells. And this in Europe these days, like they are doing a universal leukoreduction. So all the units with the red cells are leukoreduced because we don't need the WBCs in the red cell pack. They are of no use to us. So we have to remove them. Irradiated blood also can be used for gamma irradiation. The dose is 25 gray. Basically, it is used to prevent the graft versus host disease, transfusion associated GVHD in bone marrow transplant or congenital immunodeficiency, premature infants, and intrauterine transfusions. So, first degree relatives are we avoid taking from them. The indications when we see for the packed red cells are again any condition where there is a decreased bone marrow production, like leukemia or aplastic anemia, and the bone marrow is not able to produce the required or desired level of the red cells. In decreased red cell survival conditions, when there is a hemolytic anemia like thalassemia, the red cells are being destroyed. So the red cell volume and the hemoglobin is not maintained. In bleeding patients, again, it is required. So, I want to just go through the guidelines for the red cell transfusion, which have been recently published by the Blood Transfusion Practice and Hemovigilance Guidelines for the clinician from the NIB uh, Ministry of Health and Family Welfare 2022. So, there is no set level of hemoglobin which indicates the need of transfusion. If the patient is hemodynamically stable, adult or pediatric patients, then if the hemoglobin comes to less than 7 gram, then you may think of transfusion, but you need to assess the patient first. Okay, clinical assessment is very vital. Post-operative, if the surgical patient, if there is an 8-gram hemoglobin, then you can think of red cell transfusion. But if the patient is hemodynamically stable with there is no pre-existing cardiovascular disease, then you do not need any red cell transfusion. But if he has symptoms like chest pain or hypotension, then you may think of a transfusion. Each unit of the transfused red cells, which are prepared from the 450 ml of the whole blood, is expected to increase the hemoglobin by about 1 gram. So, in a patient of about 70 kg body weight, if you give one packed red cell, then hemoglobin, you expect that the hemoglobin will increase by about 1 gram per deciliter. So, coming to the other component, which is platelets, you can have platelet concentrate, random donor platelets, which are easily, routinely prepared in the blood bank. The volume of this one unit is around 50 to 60 ml. The shelf life is just 5 days, and has to be kept constantly in the agitation. This is a platelet agitator, and at 22 degrees, so the temperature is 22 degrees, and these are the plates which will constantly move from side to side, and this is how the platelet component is stored in the blood center for 5 days. So when it is issued, it should be immediately transfused, and usually in from one unit we get around 5.5 into 10 raised to power 10 per platelets from one unit. Cross matching is absolutely not required. We'll see later on how each component is to be issued from the blood center, and of course in thrombocytopenia the indication is like that. Another platelet product is the apheresis platelet product, the single donor platelets. So why we're using is this? Because it will reduce the donor exposure, because one unit of this platelet is not sufficient for a 70 kg person. It is going to increase only a 5,000 platelet count. So when we are using this single donor platelets, which is prepared from using this machine, which will bring out the blood, and which will bring out the blood, and it processes, and only the platelets are collected, and the rest of the red cells are going back to the donor. So healthy donor is there who is giving SDPs. We get this good yield, which is equal to around 6 random donor platelets, small units. So this will give you 3 into 10 raised to power 11 platelets. So this volume is again 6 times of this, so around 200 to 250 ml. And this one more advantage is that this donor can donate platelets every 48 hours. And after a whole blood donation, if he has done a whole blood donation, he can donate after every 7 days. So when we compare the single donor platelets versus the random donor platelets, a single unit, so this is This has got a bigger volume. It is as good as an and one adult dose around 30,000. It will increase the platelet count, and there is a number of the donor exposure to the patient. Here, if we are using, there will be six donor. Will The patient will be exposed to six donors, but here there is only a single donor, and we can give ABO matched platelet support. It will ensure adequate dose, and a standardized yield and consistent yield is there of this product. Coming to the guidelines for the platelet transfusion, again, it is very inappropriate usage is there among the clinicians, and there are very wrong misconceptions. So, till 50,000 or 1 lakh count, a transfusion is absolutely not required. If there is a moderate uh, count increase, I mean less than 50,000, if transfusion can be given if there is the patient is symptomatic or he has to undergo a surgery. And for neurosurgery, again, there are different levels. The patient's count should be around 1 lakh. And if there is a severe thrombocytopenia and the platelet count is less than 30,000 and there is an increased risk of bleeding, then we give. Or when the count becomes less than 10,000, then a prophylactic treatment can be given. So, dose of the platelet is 1 unit per 10 kg body weight. So, an adult dose is 4 to 6 units of the random donor platelets, but from a single donor platelet, 1 unit will be sufficient. Coming to fresh frozen plasma, it is prepared by centrifugation of the whole blood, and it is frozen within 6 hours of the collection to preserve the labile clotting factors. We can store this at a frozen state at minus 30 for around 1 year. So, when we need to use it, again, at the time of issue, we thaw it at 37-degree water bath, and it should be ABO compatible, and it is indicated in the multiple clotting factor deficiencies. The dose again of this is around 10 to 15 ml per kg. So, around this is around 100 to 150 ml. So, around 3 to 4 units of this would be required. So, points to keep in mind in fresh frozen plasma: never use it as a volume expander. It is, carrying its own risks, and it is also used in the plasma exchange as a replacement fluid. And we do not use it to correct the abnormal prothrombin time and APTT value. We have to correlate with the patient's clinical condition. Coming to the last component, it is a cryoprecipitate. You can see a yellow precipitate like thing in this bag. It is very less, it's 10 to 15 ml. It is prepared from the FFP which was frozen. We thaw it under 4-degree, under controlled conditions. At 4-degree, when we thaw it, we get these precipitates which are rich in factor 8. So, again, when we need to use it, transfuse it, we thaw it. Again, it also can be used for 1 year and stored at minus 30-degree. So the use is hemophilia, von Willebrand disease, DIC, so coagulation factor diseases, and fibrinogen deficiency can be cryoprecipitate treatment can be done. When we look at the storage and shelf life of the components, the red cell component is to be stored at 2 to 6 degrees. Red cells with additive solution, again, the same storage temperature. The shelf life of the red cells is 35 days, but when we are adding additive solution, we increase the shelf life to 42 days. The red cells and with the additive solution or without, we need to do a compatibility testing, and it has to be ABO matched, ABO and RH matched. So this is very, very important. We cannot give it across the group. We have to be very careful that it has to be done. A compatibility test has to be done, and only then we can use it. The fresh frozen plasma can be given ABO compatible, can be stored up to 1 year at minus 30 degrees. Platelets, as I already told you, stored at 22 degrees for 5 days only, and preferably we are giving ABO matched. Sometimes when there is a red cell contamination, so they can be given across the group, but when there is a slight red cell contamination in the platelets during preparation, then it is So that could lead to a reaction. So preferably it has to be ABO matched. Cryoprecipitate also again will contain no red cells, so it can be given across any group. So again, a very important slide. What are the donors and what are the recipients? Which blood group can be given to which patient? So as you know, the group O, blood group O is a universal donor. So blood group O donor will can be given to a patient who is group O, A, B, or AB. So all the O group patient donor is universal donor. Similarly, the group AB is a universal recipient. He can receive the blood from red blood cells we are talking about, the AB blood group, A, B, or O. The A blood group patient can receive blood from A donors or O. B group can receive blood from B or O. So this is only for the red cells. When we talk about plasma components, so AB plasma can be given to any patient. It is opposite. For red cells, group O is the universal, but for plasma, group AB is can be given to any patient because it hasn't got any antibody, neither anti A nor anti B. So it can be given to any blood group patient. So again, one slightly we already talked about this, whether how much hemoglobin rises there after a red cell transfusion. So having a adult having a blood volume of around 70 ml. The 70 ml per kg we have to if there is a patient, then the increase in hemoglobin after 1 unit is 1.4 gram per deciliter. So if there is a 60 kg patient, then the rise is around 1.2 gram per deciliter. I would want to give you a brief about what is patient blood management. Since a few years, this terminology is widely used now, and it is an evidence based multidisciplinary approach to optimize the care of the patient who might need a transfusion. So, the focus of the transfusion medicine is changed from the blood product to the patient. So, it is a patient centric approach, and patient centric decision has to be made, and the blood transfusion has to be optimized. The primary aim here is to improve the patient safety and the clinical outcome by appropriately utilizing the blood components. It is basically of three pillars. So, the first pillar talks about optimizing the red cell mass, whether it is intraoperatively, preoperatively, intraoperatively, or postoperatively. So, like optimizing the red cell mass, like detect the anemia, correct the underlying anemia, and so on. The second pillar is minimizing the blood loss and bleeding. So, if the patient is taken for surgery, so we take care of the blood loss. We try to do a minimum, good surgical techniques can be used to minimize the blood loss and the bleeding. And the third pillar is harnessing and optimizing the physiological reserve of anemia. So it is a multidisciplinary approach and a patient specific team approach. So, preoperative strategies which we can use are identification of the anemia and optimizing. If there is an iron deficiency anemia, we correct it and then take the patient for surgery. Elective surgery is postponed till the anemia correction is there. So, we can avoid the blood transfusion. So, then the bleeding risk assessment can be done, and the use of the autologous blood donation can be there. So, few blood sparing strategies. If there is the patient can be autologous transfusion can be done in many orthopedic surgeries. The autologous transfusion is done, and alternatives to blood like plasma expanders, recombinant growth factors, RBC substitutes, platelet substitutes, and pharmacological agents, topical agents, and a good surgical and anesthetic technique. So all these, when we use combinedly, we can we can avoid the blood components. Again, in post-operative, what we can do is we can collect the blood from the drains, we can recover the blood from the drains or wound, and although there are many contraindications for this, like in the cancer surgeries, we cannot do this. So whatever there are specific indications where we can do this post operative blood recovery. The blood is collected, and if there is a sufficient amount of blood loss, say more than 500, then we can collect the blood and we can use a strain, and then this can be reinfused to the patient. So this can be washed, and it can be given to the patient. So fibrin glue also can be done used as a topical hemostatic preparations when there is a active bleeding. So it will seal the leaks in the dura mater, or in plastic surgeries it is widely used. So just I want to talk about fresh blood. Actually, it's a misnomer, and there are many definitions to it. There are 4 to 5 definitions of this fresh blood, and when you also Google it, or if you read it in different books, some say that 5-day-old blood is a fresh blood, or 7-day-old blood is a fresh blood, or less than 24 hours is, many cardiac surgeons, they want fresh blood. They will say, okay, you collect the blood in the morning, and within 3-4 hours issue it to us so that we can use it for the surgery. But actually there are some disadvantages. There are some logistic issues. There is inadequate time for the screening for the transfusion transmitted infections, and component preparations also takes 3 to 4 hours, and increased risk of disease transmission could be there. Increased risk of transfusion associated GVHD could be there. So uh, as per my understanding and as per my knowledge, fresh blood is a misnomer and we should not use it. So the equal whatever you need, whatever blood component or the composition inside the blood, whatever your indication for the transfusion is there, it can be competed through the other blood components like the packed red cells or the fresh frozen plasma, that also are equally effective. So, when we talk about blood loss and transfusion, up to 15% blood loss, if it is there, blood volume is lost, then you just don't need to transfuse blood. If there is around 15 to 20%, then you can, do a fluid replacement like crystalloids or colloids. If you have more than 25% of the blood loss, then you can think of doing a blood component transfusion. So when what is massive blood loss? So lot of blood is around 10 units of packed red cells within 24 hours if we are issuing, if the patient needs, or if there is a blood loss which is 1 to 1.5 fold of the body's entire volume, you know. So that is around approximately 5 liters of blood is there in an adult patient. So if the whole is within 24 hours, it is you are expecting that this much loss is there, then it is called as a massive blood loss. And so whenever there is such a trauma case or something like that, then then the blood units which can be given immediately to the, because you need to resuscitate the patient first. So whatever you need to give first, you can start with the IV line and restore and maintain the circulating volume, and then O negative red cell concentrate can be safely given, which no blood grouping or no cross matching is needed. If you have some time, you can start giving at least 2-3 units of the red cells, O negative red cells, and then you can, when you have time, you can simultaneously, the blood center can start doing a blood grouping, and then ABO matched group specific units we can give. Coming to a few mm, some points on how we should administer the blood protocol, for the safe administration of blood, which is equally important. So whenever there is a request for the blood component, this type of a form is getting filled where details of the patient, name, family name, hospital registration number, the unit, ward, ID, etc., unique ID, all this is written. And the blood product, which particular blood product is required, what time it is required. It could be a planned surgery, so you need it tomorrow, or you need it immediately, or there is dire emergency, how much quantity you require, because especially in pediatric patients, you need less volume of the blood. Then the indications of the transfusions, lab reports. So all these things are captured in the request for the blood component, and when the sample is also sent for the blood grouping and cross matching, proper identification of the patient is done, and then a legible name of the doctor with signature is sent along with the blood sample. So, very important, we need to take informed consent of the patient, a written informed consent after explaining the risks associated with the transfusion and other alternatives to the patient or relative. These have to be explained, and this has to be documented in the medical records of the patient. So, as you can see, as I told you earlier, if there is an emergency, you need to communicate with the blood center that it is what urgency is there, how much urgency is there. If you have really no time, patient is bleeding a lot, so then you can give group own Rh negative packed red cells. If you have a few minutes, you can do the blood grouping, and then group specific blood can be given. Meanwhile, you can do a ABORH type and immediate spin cross match. This takes around 30 minutes, and this type of process can be done. So, if it is an elective and planned surgery, then definitely you have good time. So, you can send the sample to the blood center and you can tell them when you need the blood, and they will keep it ready and keep it cross matched. So when you are giving transfusion, so first of all, you have to check the identity of the patient. We have seen many cases where there are, wrong blood administration to the wrong, patient has been done. This it happens in government, public hospitals where there is a lot of influx of the patient, and uh, there could be, a similar name or same name patient with two patients with the same name. So, identity check of the patient before transfusion is very, very important, and you have to certify that whatever in the blood request, the blood group and the ID was there, name and everything has to be tallied with the label on the blood unit, right? So, the label of the patient, issue label, with it will carry the patient's name and the ID. So, that needs to be there. So, ideally, no medication or no drug should be added to the blood bag simultaneously, should not be given. But exception is normal saline. Okay, so ringer lactate can cause clot formation, so it should not be given. 5% dextrose also can cause hemolysis, so at least, especially from the same IV infusion set, it should not be given. So albumin and 2% dextrose can be given. Again, ringer lactate and hypotonic saline cannot be given. And if you are using the open system, it will introduce there is a risk of infection. Again, we are checking the unit again for hemolysis or any signs of deterioration. Of course, it is the duty of the blood center to check before the issue whether there are any signs of blood clots or hemolysis in the blood bag. But if you can just have a quick look at the color of the plasma, if it is pink, or red cells if they are black, or if there are any signs of the leak or the seams have been opened. So this is all these are any the signs that the blood contains bacterial contamination. So it could cause a fatal reaction. So it should be checked just before the transfusion. Sometimes a lot of time has lapsed before it is released from the blood center and it is transfused to the patient. So it is lying in the ward, and it could be lying in any condition, we never know. So it is very important to check the blood bag. So, just to summarize, that the transfusion should be complete for the red cells in less than 4 hours. Use a filter, have the IV in place, identify the patient and blood unit, monitor periodically pre, during, and post transfusion. And in case of any sign or symptom of the blood transfusion reaction, you can stop and inform the blood bank. Post transfusion, we have to record the time, date, product, volume infused in the case medical records. Patient's vital data has to be monitored every 15 minutes, and then after every hour on completion, and 4 hours after completion. Unique ID of all the products transfused should also be ideally recorded in the case records, and patient is monitored for signs and symptoms of transfusion reaction. Usually, if there is a reaction, it will happen within few minutes of transfusion, or sometimes around 100 or 150 ml of transfusion has passed, been transfused volume, then the reaction could start. So if there is a no adverse reaction, then the empty bag ideally has to be discarded according to the biohazard waste disposal practices. So, as I already told you, the undesirable practices, blood warming, which are very commonly seeing, that blood warming by the hot water. So, this, friends, will cause hemolysis of the red cells inside the bag and should never be done. And if whenever you need blood, you're deciding that now I'm going to transfuse, only then you take it from the blood center, because the blood center is having storage conditions which are ideal for the blood unit. So is a temperature monitored device, storage device, blood bank refrigerator, which is specially made for storing the blood units. So the ward side will not have such a refrigerator or storage equipment. So ideally, it should be asked from the blood center or taken from the blood center only when you need to transfuse, and there should be no delay in the transfusion. Then platelets should never be stored in the 4-degree refrigerator. They will become inactive. So you will not get the results in the patients. So you need to not store, no need for storage, and you need to just take it from the blood center, and just you can transfuse immediately. So this is unmonitored refrigerator, and the nursing station should not be kept. When the rate and the duration of transfusion is not monitored, so this is also wrong practice. Then pre-transfusion medications, usually Dexona and Avel and all, should not be given, and transfusion set for more than 1 unit ideally should not be used, and any drugs to the blood bag should not be added. So, whenever you think that there is an adverse transfusion reaction, you're suspecting, you immediately stop the blood transfusion, you follow the protocols, you inform the blood center, you record the vitals, and then the blood center will do the needful and do the protocol and do the workup for the blood transfusion reactions. So I would summarize by saying that give blood or blood component whenever it is really necessary. Give the patient only what is needed, whatever component he is needing it. Give the right blood component to the right patient at the right time in the right quantity, so that there is no adverse transfusion reaction. You're avoiding this and you're doing a safe transfusion practice. Lastly, and very important, we look for the risk benefit ratio. We always try to see that the benefit should be more than the risk. And ideally, when we talk about rational use of blood and optimum use of blood in clinical forums, we just tell them that would you transfuse blood if not necessary, and what would you do if she's your mother, and would you give transfusion? So unnecessary transfusions will pose a risk or threat for the infections through which are transmitted through blood. So please avoid the blood transfusion. So no transfusion is a zero risk transfusion. Uh, Thank you so much. With this, I end. Varsha, over to you.
We do have some questions coming in from our doctors. We will be getting into that. So I'm taking one of the earlier questions that we had. It's from Dr. Kulkarni. Sir asks why blood is to be warmed before transfusion, and what is the reason of covering the blood packet during the transfusion?
So, as I went through my presentation, I think this was already covered that blood need not be warm. So, it is a wrong practice. We absolutely don't need the blood to be warm. When we are asking the blood product from the blood center, there are many final checks, right? So, during that process, we are pasting an issue label on the blood unit or the comp, and we are doing some final checks, right? So around 30 minutes from the hospital from the blood bank to the ward side, around 30 minutes will easily pass, and that is usually usually these blood reports are very are being done. It is kept at 4 degrees. In 30 minutes, the temperature of the red cell unit will come to 10 degrees or 10 15 degrees. So it is absolutely safe. So it is absolutely safe. When you start the transfusion, you start slowly with a slow rate, and then you can gradually increase it. So you will never get any reaction. So there is no need for also covering the blood packet during transfusion. So these are wrong practices.
So, moving on to the next question. It is from Dr. Bhatt. What is the indication for very costly single donor platelet transfusion?
Yeah, so actually it is safer. So only a single donor exposure would be there. So the risk of the transfusion transmitting infection would be lesser, and the dose is also appropriate. So definitely it is a better product.
So, moving on to the next question. Dr. Kulkarni asks why RDP transfusion should be fast.
Because it is a very small unit. It is only 50 ml. So it will finish off in 10 to 15 ml minutes. So we do not say that you transfuse fast, but actually the volume is very less of our RDP. It is only 50 ml. So it can be easily transfused within 10 to 15 minutes.
So, next question is there any new discovery in extending the life of short life platelets?
So there are many studies going on, and actually, the platelets at few centers and in Europe they are keeping it for the 7 days also. But in India, we are governed by the Drug and Cosmetic Act, and in that, like we are, bound by that, so that we are just allowed to keep it for 5 days. So there are platelet additive solutions available now, which do extend the shelf life from 5 to 7 days, but not beyond that.
Next question from Dr. Madhav. Which blood component is ideal for second degree burns?
So plasma is the fresh frozen plasma is the component which is used for the second degree burns, and usually we do have plastic surgeons asking for it. So that is effective.
So Dr. Atma Singh asks, when does transfused blood become functional?
Okay, once you mean to say that when there is transfusion, so yeah, so that is immediately, like the yeah effect that will be it. It is all already, because once you transfuse the whole thing, like within a day the hemoglobin level will be increased.
So Dr. Dubey says, have you had any personal experience of blood transfusion between different groups?
As I said, I showed a slide which said about the compatibility. So, what blood, like the blood group, O blood group, it's a universal donor. And so that's why the O negative, RH negative also. So, this is a safe, it has not got any antibodies. So, we can give it to any patient in dire emergency. So, we need not, when we do not have the time to do a blood group for the patient, we can give O negative blood to these patients. So yeah, definitely we can give.
So next question from Dr. Kulkarni. What are the precautions that is to be taken for recycling of blood transfusion?
So recycling of blood transfusion can be done when there is a lot of blood loss, and it can be done in certain surgery. So the patient should not be having any malignancy. So that is one contraindication. We cannot collect from those sites and then recycle the blood.
Dr. Shivani asks why the filter is required in transfusion. What is the rule?
Routinely, the BT set, the blood transfusion set is there. So the in the patient. So to avoid that, we are using these blood transfusion sets. So it has got a small filter, 170 nanometer is the size. So ideally, it could be patient filter bed and a lab site, both are available. So that is the role of the filter. We need to, avoid the clots.
Taking the next question from Dr. Tarun. What to do if the patient has hemoglobin of 3 gram per deciliter with fever?
So, Dr. Tarun, even if the patient is having fever, you can treat the patient. That is a separate, symptom altogether. Definitely, if he has a hemoglobin of 3 grams, he needs a blood transfusion. Definitely. So, you can easily, maybe you can give him a antipyretic, and then safely blood transfusion can be given slowly. And of course, when the hemoglobin is 3, you'll be obviously doing a workup, that whether there is a bleeding, active bleeding or not. Those things you will be already been doing. But of course, yes, blood transfusion can safely be given even if there is fever.
Next question from Dr. Naidu. How many units of PRBC can be safely transfused per day in a cancer patient, non-hematogenic, who is having active bleeding and the hemoglobin is around 4 to 5 gram per deciliter?
So active bleeding, when we say, Dr. Sankalp, we need to first of all address that. So simultaneously, uh, I think there is no cutoff as to how many units you can give per day. So it depends upon, like, maybe at a time you can give 2 units, then you can, maybe in the morning you can give 2 units, address the active bleeding. Then after, say, maybe a few hours, that this will go, the transfusion for 2 units will take you 3 to 4 hours or maybe 5 hours. As we say, within 4 hours, 1 unit should be completed. So then you can reassess the patient, and then you can again give. In massive transfusions, what we are giving in massive blood loss, if there is a trauma patient bleeding actively, so we are, doing, giving platelets, giving a 1:1:1 ratio. We're giving red cells, we are giving platelets, we're giving plasma. So in that way, there is no cutoff, or there is no uh, set limit as to you cannot give the more units of a limited transfusions. So you need to assess this patient who is actively bleeding, and then maybe give 2 units and then reassess.
Dr. Jayashree asks, whole blood transfusions are not available nowadays. Why is it?
So, Dr. Deshri, I already covered this point in my talk, that whole blood transfusion has very limited role, and whatever, because it has got it has got some more disadvantages. It is giving you more volume overload will be there, and it has got WBC, it has got platelets, some unwanted substances. So that is why we are avoiding the whole blood transfusion. The same thing can be addressed with the packed red cells or different components.
So next question from Dr. Prajapati. If someone is IgA deficient and we don't know the status, what will be legal if it went wrong? That is anaphylaxis or any other transfusion reactions.
So, as I told you, that informed consent has to be taken before blood transfusion. So, definitely, you are telling the patient that there could be a blood transfusion reaction. When we are transfusing blood, there could be a reaction. So, it could be allergic, anaphylactic, or febrile reaction, right? So IgA deficient is there, and we do not know about it, and the patient is went into, if it is anaphylaxis, it is a severe type of a transfusion reaction, right? It's a type of allergic which is severe. So immediately the patient will have some symptoms, right? Rigor and urticaria and all. So immediately you will stop the transfusion and you will give the medication. So legally, you are safe because you've taken an informed consent from the patient or the patient's relative. It was required, that is why you are giving the transfusion. So, the best interest of the patient, you have done the transfusion, so you are safe legally.
So Dr. Naidu has another question. Can we give romiplastim along with RDP infusion?
Uh, I have no experience of this romiplastim and along with the RDP infusion. I think, as I said, with any transfusion, there has to be no drug. So you cannot give it simultaneously, but maybe space it.
So Dr. Shah asks, blood grouping and cross match is not required in transfusion of which blood components?
Cryoprecipitate does not require any blood grouping and cross matching, and even platelets, you do not need cross matching.
So Dr. Dubey has a follow-up question. Do you have any personal experience of such transfusion between different groups, and what was the aftermath? If you don't mind, if you could share.
I'm not sure what. Suppose there is a patient who has blood group A, so he can be given either blood group A blood unit or an O. That is safe. Doesn't happen. It would not have any risk. So the chart I showed earlier, which blood groups can give, that can be given safely. There's no problem.
Dr. Bhatt asks, how often does Bombay antigen occur?
So it is rare. Bombay blood group is rare, but we do come across in certain areas of, say, the western region of India. So we do come across Bombay blood group. Say it is, but the percentage is around, say, 1% of the population. Not much.
So, ma'am, is it okay if we take a few more questions?
Yeah, one or two maybe. Yeah, sure. Go
Yeah.
ahead.
So, next from Dr. Krishna Priya, what are the precautions that are to be observed during the blood donation camps?
Yeah, so when you're planning a blood donation camp, you need to have a very nice ambient, atmosphere, so that the donors who are coming, they're very enthusiastic. So there should not be any overcrowding. The space should be appropriate. Preferably, it should be air conditioned, and the spacing should be appropriate over there. And proper donor screening should be done. Medical checkup and screening should be done. Usually the donors in these camps, they are very enthusiastic, so they would, even if their hemoglobin is little less, suppose the 12.5 is the cutoff, so even if it is 12, they will force. So certain these things should not be done. And uh, post donation also, there should be some chairs comfortably, so that the donor post donation can sit properly and have some refreshments, and you can observe them after donation also.
So, doctors, in the interest of time, I'm going to be taking one last question, and whatever questions are unanswered, I will be passing it along to ma'am, and ma'am can answer according to her convenience, and we will get it answered.
Sure.
So, taking the last question. So, Dr. Shivani says, if the wrong blood has been transfused, what can be the complication and how do we tackle that?
So, Dr. Shivani, if the wrong blood transfusion, first of all, you need to do a workup. You have to be a Sherlock Holmes, and you have to investigate why there was the wrong blood transfusion in the first place. Do all the clerical checks, and the routine. What protocols we are following is we do a clerical check. So first, whether the yeah, to start with, whether it was a WBIT, as we call it, wrong blood in tube. So suppose there is a patient A, and if the label is patient A, but the blood in the tube is of the patient B. So, and in this case, the sample comes to me labeled as patient A in the blood bank. I am doing a blood grouping. So I'm uh, telling you that this is a blood group A, but the patient A, but the label is of A, but the blood is of patient B. So wrong blood in tube. If this is the case, then there is a mismatched transfusion. I will issue only the A blood unit, and it will be transfused to the patient. So when this is there, then of course there could be a fatal blood reaction if a patient of A is given a blood group of B. So there could be a fatal reaction, and we have to immediately stop the uh, there will be a reaction. So hemolytic transfusion reaction will be occur. Patient will have urticaria, shivering, fever. So immediately blood transfusion has to be stopped, and then patient has to be resuscitated. And again, during administration also it could be there, and in the blood bank also there could be a mismatch transfusion.
So, doctor, since there are a lot of questions, it is not possible to get all of them answered, but I will be passing along the unanswered questions to ma'am. And like I mentioned, ma'am can answer it according to her convenience,
Sure, sure,
and we
sure.
will be getting them answered. With that, thank you, ma'am, for taking in so many questions from our doctors very patiently. Thank you once again for this wonderful
Thank you
session, and we
very
really
much.
hope to see you again on Netflix, ma'am. Thank you, ma'am.